Mayo Clinic presents
Emergency Medicine Grand Rounds.
Out of the night that covers me, black as the pit from pole to pole, I thank whatever gods may be for my unconquerable soul. In the fell clutch of circumstance I have not winced nor cried aloud. Under the bludgeonings of chance my head is bloody, but unbowed. Beyond this place of wrath and tears looms but the horrors of the shade, and yet the menace of the years finds, and shall find, me unafraid. It matters not how strait the gate, how charged with punishments the scroll. I am the master of my fate. I am the captain of my soul. Welcome to Always on EM, a podcast from Mayo Clinic Emergency Medicine. My name is Venk Bellamkonda. I am an emergency physician and one of the two hosts of this show with my dear friend Alex Finch. I open this show with the immortal words of poet William Ernest Henley. He is believed to be reflecting upon his courage in the face of death from tuberculosis, and to be inspiring himself to hold on to his own dignity despite the indignities of the disease. Today, for our Mayo Clinic Emergency Medicine Grand Rounds show, we are incredibly honored to share a presentation from a true world expert on the topic, Dr. John Wilson. Dr. Wilson is a professor of medicine and a consultant in the Division of Infectious Diseases here at Mayo Clinic. He has particular expertise on tuberculosis, as you might imagine. He is highly decorated and accomplished in his career thus far, including having won Teacher of the Year twice before, several awards for his pioneering work in international medicine, including having founded the Mayo Program in Underserved Global Health, which has helped elevate care for people throughout the world, including Belize, El Salvador, Haiti, and more. Specific to mycobacteria and TB, he has given so many presentations in a variety of regional, national, and international sites on these topics that it has filled almost a whole page of his CV. He is a member of the IDSA CDC Guidelines Writing Group for Drug-Resistant TB Management and is the director for TB consultations for the Mayo Clinic Center for Tuberculosis. He has received federal funding for research on tuberculosis and has turned that into nearly 90 peer-reviewed publications, approximately 40 book chapters, and so much more. So when we want to understand one of the most impactful conditions in the history of humans on this planet, there are really none more qualified than Dr. John Wilson. John, take it away.
Thank you very much. I'm thrilled to be here today, and thank you for the invitation to talk about tuberculosis. When I prepared this talk, a number of slides are going to be fairly basic for many of you, but I also included some updated information pertaining particularly to treatment options that have recently come about. So there is a lot of information in these slides, so I'm really going to go fairly quickly and hoping to reserve some time at the end for some questions and comments in that capacity. So without further ado, let's go ahead and dive into this. So why does tuberculosis matter? This particular infection remains a very common and second leading cause of death from an infection pathogen worldwide. COVID, unfortunately, remains number one in that regard. And TB-related fatalities still compose about 2 times the degree of mortality compared to HIV infection. Globally, this is a very, very common infectious diseases. Over 7.5 new cases of TB reported annually, and this is felt to be a gross underestimate, with at least 10 million, and by some estimates, close to 15 million cases annually. And this number continues to go up in that regard. TB causes an estimate of 1.3 to 1.5 million deaths annually as well. So this is high on the radar for the World Health Organization regarding pivotal infectious diseases to target for funding and eradication efforts. Where is TB globally? Well, the short answer is it's everywhere, including the U.S., including Minnesota in that regard. Although we're a low incidence area, Olmsted County has its fair share of tuberculosis. But we still see the highest concentrated regions globally in sub-Saharan Africa, South African region, Indian, Pakistan subcontinent, as well as Southeast Asia, Polynesia in that regard. Much of our drug-resistant cases are coming from Southeast Asia and Eastern Europe. But the demographics continue to change. Here in Minnesota, most of our cases are from individuals born outside of the U.S., and we see a higher preponderance of active cases in individuals from Eastern Africa, so Somalia, Ethiopia, Eritrea, but also from Southeast Asia, Laos, Thailand, Burma, for example, and also including drug-resistant cases as well. This certainly does not exclude other parts of the globe, but these are the areas that are particularly more common for what we encounter in Southeast Minnesota. Here in Minnesota, the Twin Cities have more heavily concentrated numbers of active TB cases in Hennepin and Ramsey County for Minneapolis and St. Paul. But Olmsted, Stearns County have had a number of cases. There's a current clustering in Albert Lea as well with a Burmese Thai community. So again, throughout the state, tuberculosis is alive and well, and something that all of you no doubt will be encountering in the ED setting as well, and thus the rationale for this talk today. So to deal with tuberculosis, both education and consultative support, the CDC has funded 4 centers across the country. Mayo Clinic is one of them, and you can see in yellow, this is the demographic of states that we support not only for medical consultation, but also educational activities for physicians, for nurses, nurse practitioners, public health. The Francis Curry Center in San Francisco covers the western third of the country. Gainesville, Florida, SNTC is for the southeast, and Rutgers University Global TB Institute is in New Jersey. So the 4 of us work together, also including U.S. territories, the Pacific Islands, Puerto Rico as well. So this is a concerted effort to really support an infrastructure for TB management and communal education. So one of the more common questions that we handle right out of the gate is infectivity to others. This is a highly communicable infection from person to person, thus the interest from WHO and CDC in that regard. Generally, when we talk about infectiousness, this is among individuals with active pulmonary or respiratory tuberculosis. Extrapulmonary generally is not communicable to other individuals unless there's concurrent pulmonary disease. Now, there are exceptions in that regard. We always let our surgeons know in the operating room when someone has extrapulmonary or bone and joint disease that they may be debriding, because water picking procedures can aerosolize material and thus result in secondary pulmonary inoculation. Also with autopsy, the bone saws, drilling sometimes can have that similar aerosolization effect, but these are very uncommon. So pulmonary is really where we pay most attention regarding infectivity to others. Now, historically, when I was in medical school and residency and fellowship and so forth, the traditional training was take a patient history, do the exam, look at the films, look at the lab tests, and come up with the approach of active or latent TB infection. A better approach and what we focus on within infectious diseases is basically a 4-step: defining the host, defining the syndrome, or what's the area of inflammation, the itis, if you will. If the microbiology is known, great. If it's not known, what are other considerations besides tuberculosis in that regard? And then finally, the underlying treatment predicated on the host, the syndrome, and the microbiology. So let's go into greater detail. What do I mean by that? So when I talk about the host, part of this focuses on, is this an immunocompetent or immunosuppressed individual, whether it's HIV infection, whether it's an individual on immunosuppressive therapy for a hematologic, oncologic condition, autoinflammatory. Maybe there's other medical comorbidities that have not as severe of an immunosuppressive effect, but some immunomodulatory impact, like poorly controlled diabetes. Young children with immature immune systems also are more vulnerable in that capacity. And also the living status. What is the risk of a concentrated exposure? Is this an individual coming from jail, the Rochester FMC, for example, a homeless shelter, a college dormitory, if you will, or a refugee camp in Kenya that might have a higher risk of communicability? And these issues all interplay. So, for example, an otherwise healthy, immunocompetent individual who's infected with the TB bacteria or exposed in that regard, the organism infects their lungs and it generates an appropriate immune response. The vast majority of these individuals will be fine throughout their lives. The immune system will destroy the TB bacteria, but they still may have roughly an 8 to 10% lifetime risk that the TB bacteria is not destroyed and can cause reactive tuberculosis. This goes up about 3-fold in an individual with diabetes and exponentially in an individual with HIV infection, even with immunologic reconstitution with effective ART. So this can be up to 7 to 10% per year in somebody with active HIV. In infants under 2 years old, the risk of not only active infection, but disseminated and CNS disease can be up to 40% because of that immature immune system. So again, the immunologic status of a host is quite important. So then we move into, well, let's get into the itis or the syndrome. Where's the area of inflammation? Because our diagnostics and our managerial strategy will be different and predicated on where this is. We'll commonly make the distinction between latent TB infection or inactive. This is the TB exposure, but the immune system either destroys off the TB bacteria or walls it off into granulomas, or active TB disease where there's active infection, inflammation, and in the lung standpoint, potentially communicable to other individuals. When we talk about LTBI, the diagnostics are indirect. We go after an immune system activation, and with active TB disease, we're actually trying to diagnose the actual TB bacilli from a variety of respiratory samples. So it sounds clean to say either LTBI or active TB disease, but the reality is this is a continuum. And as you can see from the pictorial below, on the far left, an individual with latent TB infection, the vast majority will completely clear the TB bacilli from their immune system. It may be macrophages knocking out the bacteria in the lungs or activated T cells that are recruited to destroy the TB germ. But there are a number of individuals where the germ is still quite active and maybe slowly replicating, but no active TB disease. And these are the ones that benefit the most from LTBI treatment. But it's important to note a lot of individuals we see might actually have subclinical active infection, active disease, but we can't see it on chest x-ray. So for all the patients with LTBI that has a clear chest x-ray and a normal physical exam, we did CT scans on all of them, and I'm not recommending this, but if we did hypothetically, we're probably going to pick up very small areas of mild inflammation that may or may not reflect subclinical TB disease. The good news is the bacillary burden is so low that LTBI treatment regimens generally are quite effective and take care of that. So why do we care about latent TB infection? Again, this is infection without active disease. And this is because roughly a quarter of the global population, around 2 billion people, have been infected with the TB bacteria. And again, when we think about an 8 to 10% lifetime risk of developing active tuberculosis disease, you can see where these numbers come from, of anywhere between 9 and 12 million cases annually and 1.3 to 1.5 annual deaths per year. But it's important in this country that roughly 80% of the active cases come from individuals previously diagnosed with latent TB infection and were never treated. And so this is what CDC focuses on, is a huge opportunity for identifying these individuals with LTBI and treating them to lower the US case rates of active TB disease. So how do we do this with latent TB infection? What are our diagnostic toolkits that we consider? As all of you know, the tuberculous skin test, this was something that's been in play now for over 40 years. This was the go-to test when I was a medical student and resident and fellow and a number of years on staff. Its roughly, its sensitivity is anywhere between 60 and 70%, but specificity is terrible. As all of you know, prior BCG vaccinations or select NTM infections can give false positive skin test reads. It's also very subjective, and so this can be overread or underread. And in general, the skin test is just not that good. Thankfully, now we have interferon gamma release assays, which are blood draws, which measure in vitro production, T-cell mediated production of gamma interferon from sensitization in that capacity. Mayo Clinic uses the quantiferon assay produced by QIAGEN. There's also the T-spot assay from Oxford Immunotech that can be done. Both of them measure the same thing, albeit different ways. The specificity is much, much better, close to 98%, with a better sensitivity close to 90%. So these are good tests. They're not perfect, but they're definitely better. This is what the quantiferon, yeah.
What are the false negatives? You couldn't see that.
The false negatives, so it's roughly let's see. Oh, yeah, I wonder if I can move this. Let's see if I can move this. There we go. So with the IGRA testing, anyone who is immunosuppressed certainly can have, and what do I mean by a false negative? Oftentimes this will be an indeterminate where you won't get a positive control. So without a positive mitogen control, you'll oftentimes see indeterminate where the TB antigen 1, TB antigen 2 are negative, the mitogen may be negative. So again, very dependent on a functional immune system like the tuberculous skin test is. Let me see if I can get back going here. There we go. When the blood's collected, it's put into one of 4 tubes. The testing tubes are the green and the yellow, TB antigen 1, TB antigen 2. There's the negative control, which is nil. There's the mitogen control, which should produce a positive control. And this goes into an algorithm looking for measurable gamma interferon production. The other assay is called a T-spot. Again, measures gamma interferon, but this is by clumps of T cells in vitro that are producing gamma interferon and discolored. And so it's counting spots within a dish in that regard rather than laboratory measurement of quantiferon, but the end result is essentially the same. These assays both also have comparable sensitivity and specificity. So this sounds really good when we're testing individuals that were suspicious for TB infection or active TB disease. The problem is, what if we mass screened everybody without risk factors? And this applied largely to healthcare personnel of low to medium incident areas, and Mayo Clinic being one of them in that regard. So yes, I see patients with active tuberculosis. There's a rationale for my testing for TB infection, and all of you working in the emergency department, you're actually at higher risk than I am, because 9 times out of 10, I know when a person's coming to see me with TB. For you guys, you're actually more on the front line. But if you're an individual without patient care duties in that regard, or you're taking care of patients without communicable issues, there's real concern that that 1% may be a false positive. And indeed, 98 to 99% specificity in a low incidence area means that when we do get a positive, we have to be careful that in a low risk area, is it real? So for somebody with risk factors or immunosuppressed, I believe it, I don't question it, it's important. But without risk factors for an immunocompetent host, there's a real risk that this could be a false positive, and also what's called what can result into a conversion reversion. And what do I mean by that? This is a nice study actually done about 12 years ago with 3 medical centers across the country. And they actually studied amongst health providers with low risk for tuberculosis infections. Those individuals who had positive results on a quantiferon were retested. And there was a staggering number of those upon retesting who had subsequent negative results. These were tested usually between 3 and 6 weeks later. So again, when 186 people tested, retested, 113 of those in the VA at Palo Alto were positive, but 73 were negative. And you can see at University of Chicago, Illinois, it was even a larger number that went from positive to negative. And this was just some of the variability that gamma interferon release assays like quantiferon and T-spot can confer. So much of this comes down to what are the risk factors of this person indeed having a TB exposure, or are they have some kind of immunomodulatory condition that if infected, the risk of TB disease in the future is non-trivial. So for these reasons, testing individuals in low-risk settings, including healthcare settings with low TB incidence, has now been dropped by CDC and Minnesota Department of Health. I'm not sure that includes, I don't think it includes you guys. It doesn't include me either. But for most of other hospital-based specialties and such, the annual testing now is gone. So when we talk about defining the syndrome in active TB disease, it's a different type of conversation. We focus on the location. Is it pulmonary? Does it clinically and radiologically fit? Is it possibly extrapulmonary disease, something that all of you will encounter in the ED setting, such as lymph node involvement, CNS involvement, pericardial? We'll go into this in a little bit later on. Are we sure it's active tuberculosis disease? Does the syndrome fit? And we'll talk about that in just a moment. Or could it be a non-TB mycobacteria or something that looks like TB radiologically, like nocardia or even fungal infections, histo and blasto and such? Is it possibly drug-resistant TB? Has this person had treatment in the past, or have they been exposed to an individual with drug-resistant TB? You know, the concerns for active infectiousness, again, with pulmonary disease is what our focus is, but also upper airway involvement. Laryngeal TB occurs, which can have a higher infectivity. It's important to define location and syndrome because the diagnostic approaches are contingent on that. So for pulmonary or upper airway cases, we're going to be focusing on sputum collections or BAL if we can't get quality sputum collections, or with extrapulmonary, it depends on the location. If it's in a lymph node, we might do a needle biopsy or talk with our ENT colleagues on doing an excisional lymph node biopsy, or collect fluid from urine or stool or pleural fluid and so forth. And the treatment, which we'll get into in a moment, is going to be based syndromically on where TB is and whether or not there's steroids involved, or the duration of therapy can be somewhat variable. So let's get into some of these different syndromic presentations of active tuberculosis. And I know many of you have seen these before, and I'm preaching to the choir, but I'll go through this fairly quickly here. So when we talk about primary pulmonary tuberculosis, rather than reactivary disease, which is more common in adults, Primary disease is infection, but a continuous proliferation of the TB bacilli in an individual that leads to active inflammatory infectious diseases. This is more common in infants and children. In fact, it's usually the typical presentation in children under 5 or in adults with immunosuppressive conditions, including HIV infection. Again, this is less typical in an otherwise immunocompetent adult, but we still occasionally see it. So this is in a 28-year-old individual. I'm going to try to move this thing here. This is a 28-year-old woman with primary pulmonary tuberculosis with active diabetes. And you can see here she presents more now with hilar and mediastinal adenopathy in that setting. Now, with tuberculosis growing in culture, it's a fairly easy diagnosis to make. But somebody who comes into the ED setting with chest pain and coughing for 3 weeks with a CT scan of adenopathy, well, TB may be in the differential, but other things might be there too. I mean, could this be histoplasma, for example? Could it be, if it's an HIV-infected individual who's immunologically suppressed, cryptococcosis? Or in an uninfected scenario, could it be sarcoid or lymphoma or things of that nature? So, a lot of these can be lookalikes for TB, but other differential diagnostic considerations apply as well. Oops, let me try to get this going. Here we go. In children, again, sometimes it can be a little clearer. You can see that mediastinal and hilar adenopathy. It tends to be asymmetric more often in kids, although bilateral disease certainly can happen. And infiltrates could be anywhere in the lungs. And unlike adults, cavities tend to be less common in children. In adults, on the other hand, when there's infection, a period of quiescence, and then reactivation, this tends to favor more the upper lungs in that regard from the oxygen exposure, usually the apical or posterior segments of the upper lobes. But the important thing to keep in mind is TB in the lungs can look like anything, basically. Yes, we have that upper lobe classic presentation. Maybe there's a cavity there or fibronodular findings. It can be in the lower lungs. It can have a pleural effusion. It can be consolidative and look like community-acquired pneumonia. So there's no radiologic pattern that necessarily excludes pulmonary tuberculosis in an adult in that regard. These are both chest X-ray and CT scans, but also path samples of that upper lobe suppuration, which gives you that necrotic cavity formation in the left upper lobe. Here in the middle film is the chest X-ray with a right upper lobe infiltrate with central cavitation, and you can see the multifocal apical consolidations on the CT scan as well. Generally, there's more systemic symptoms with active tuberculosis disease: fever, chills, night sweats, and weight loss. Sometimes there's some optosis with that. Now, extrapulmonary tuberculosis also occurs not uncommonly. Again, it's more common in infancy because of the immature immune system, but also in individuals with some degree of immunomodulatory conditions, especially with HIV infections or any types of myelosuppressive treatment. But we do see it occasionally amongst immunocompetent patients as well, especially lymphatic tuberculosis. But again, any of these can happen in an otherwise healthy individual or immunologically healthy individual. This is an individual with cervical adenitis, or a couple of individuals rather with cervical adenitis, and you can appreciate the bulky anterior and posterior adenopathy. These tend to be painful. They can be suppurative. They can rupture. We either do an FNA or have our ENT colleagues take the whole node out. When there's a debridement without removing the node, these oftentimes fistulize and they don't heal very well. We sometimes will see this in kids not related to TB, but select NTM like MAC or scrofulaceum. But in adults, the vast majority of presentations is going to be tuberculosis, or in endemic areas of the world, even in young children, TB is quite common in that capacity. Pleural tuberculosis is very common with primary pulmonary tuberculosis, but occasionally can happen with reactivary disease as well. They tend to be more unilateral and chronic in nature. It's important when we think about this with mycobacterial disease, pleural effusions are more typical of TB and fairly uncommon with non-TB pulmonary disease, MAC, Kansassii, Chelonae, and so forth. Occasionally that happens, but it's not overly common. This is a film of a left-sided pleural effusion with an individual with pleural TB, but also upper lobe pulmonary tuberculosis as well that you can appreciate, especially in the right upper lobe. This is an individual, it's an old chest X-ray, but this is chronic pleural tuberculosis where there's scarring and secondary calcification and a true empyema that's really walled itself off over the course of many months in that regard and wound up getting decorticated. So the pleural component can really present in many different fashions. The pleural fluid characteristics actually can be quite variable. The WBC pleocytosis is listed there anywhere from 1 to 6,000 with usually a lymphocyte predominance, although sometimes polys can present early on. The challenge with pleural TB is this can be paucibacillary. So the AFB smear testing is only positive in anywhere between 10 and 15% of samples, and the culture positivity is really quite variable depending upon the volume of fluid collected in that regard. We'll sometimes add an adenosine deaminase to pleural fluid as we do with CSF, although nonspecific, an elevated level, usually higher than 250, can be much more suggestive of pleural tuberculosis. When we're struggling to get a diagnosis, doing a pleural biopsy can be helpful. It adds to that sensitivity of both stain and culture positivity in that regard. So the combination of pleural fluid and a biopsy usually can get us a diagnosis over 80 to 90% of cases in that context. Occasionally, we'll see genital urinary tuberculosis. It's not really that common, tends to be more in older individuals and also unilateral in that regard. The symptoms are not very common. I should say they're not very specific, but more fatigue, chronic back pain. Occasionally, there may be some dysuria. It's almost like a musculoskeletal back pain on somebody who didn't sleep well, but this is going on for months and months. Just a general KUB may show chronic calcifications evolving over the renal parenchyma, and this is what it can look like. There can be secondary ureteral scarring from genital urinary TB and secondary hydronephrosis as well. So a KUB can be a simple way to raise suspicion for parenchymal or ureteral tuberculosis involvement. Now, with bone and joint tuberculosis, also this tends to be older individuals like genital urinary tuberculosis. The vertebral column, particularly the thoracic and lumbar areas, are higher incidence, but occasionally we'll see it in the knee and the hip as well. With vertebral tuberculosis, this is also labeled as Pott's disease. This tends to involve a ventral portion of the thoracic or lumbar vertebrae and have an anterior destruction, resulting in the secondary chelation or gibbous deformity. And this can also be very painful and sometimes with secondary neurologic manifestations on that. When we have bone and joint tuberculosis, we generally will extend duration of therapy longer, anywhere from 9 to 12 months, just to have better and more durable bone penetration. Sometimes we'll even add to combination drug therapy for better bone penetration as well. So this is a film of how thoracic vertebral TB with that anterior wedging or that gibbous formality or that gibbous malformation can occur in the extreme sense in an individual that wound up not only getting treated for TB, but had secondary spine surgery with that. When we think about that, we think about the Hunchback of Notre Dame, and gosh, was this really a congenital malformation, or did he actually wind up having tuberculosis? And this could have been treated, it could have been cured, but it just wasn't thought about back in the 17th century. And this is also not to be confused with a halfback from Notre Dame. The two are very different, so I just wanted to be sure we weren't causing any confusion there. So when we have hip and knee joint involvement with TB, this is also very nonspecific, chronic, usually over months of pain with walking. The synovial fluid is more pleocytosis generally than pleural fluid, up to 140,000 cells. Occasionally there'll be neutrophilic predominance, although lymphocytes can secondarily be the predominant cell count. And like pleural disease, this can be paucibacillary, so AFB smears are rarely positive. And with high volume aspirates, cultures have a better yield in that regard. But oftentimes we'll wind up not only doing aspirates, but getting synovial tissue biopsies to optimize that culture yield. Oops. With disseminated TB, this tends to be more common in individuals with immunocompromising conditions. This is an unchecked proliferation of bacteria outside of the lungs and can affect basically any organ system. The chest X-ray in a typical miliary pattern will be well distributed over both lungs. It's often not seen early in disease, and the chest X-ray paradoxically can look clear in that capacity. CT scan can have a much more clear picture. And because the immune system can be overwhelmed, a tuberculin skin test and even an IGRA, quantiferin or T-spot, can be negative or indeterminate in that regard. This is a chest X-ray of miliary TB, and you can get the artist renditions of it's basically these millet seed-like BBs all over the lungs from a lack of immunologic containment of TB bacterial spread. And not only in the lungs, this can involve multiple. The cases I've been involved with were not just lungs, but hepatobiliary involvement, sometimes kidneys, sometimes small bowel, with all the immune system. So this can very easily be a multi-organ involvement in that capacity. The findings are oftentimes nonspecific: fever, hepatomegaly, splenic enlargement, so no surprise there. The diagnosis can be difficult because respiratory samples won't oftentimes yield a positive organism growth because of that paucibacillary distributed disease. So we may be thinking about blood cultures and urine cultures and stool samples and looking really from any bodily fluid, not just for cultures, but PCR to try to make that diagnosis. CNS tuberculosis is, again, more common in individuals with suppressed immune systems or young children under 5. In fact, it's very common in young children with meningeal tuberculosis. This, too, is a paucibacillary process requiring sometimes multiple spinal fluid evaluations and PCR studies to solidify the diagnosis. The cell count in the spinal fluid oftentimes will have a neutrophil predominance early, but over time, after weeks, can transition into more of a mononuclear and then lymphocyte predominance. Protein is almost always elevated, and the CSF adenosine deaminase is another assay that, albeit not specific, it generally is quite elevated, providing a strong clue that TB may be a significant consideration. Sometimes it's not meningeal TB, but conglomerates of tissue forming tubercles in the brain and having another form of TB CNS involvement. And in this context, seizures can be very common, especially after starting therapy in that capacity. Sometimes it's identified even after biopsy. With meningeal or parenchymal CNS disease, we almost always give steroids to minimize that secondary immunologic reconstitution effect, whether it's seizures or headaches or hydrocephalus. So the steroids really become an important component. Abdominal TB does occur periodically. Peritonitis is the major form. It's usually more of a distended, doughy abdomen, just vague general abdominal pain. It can be easily confused with ileocecal tuberculosis. Anatomically, it's the same location as many forms of chronic inflammatory bowel disease and Crohn's disease, but we'll see it in the mesentery as well, gynecologic tissue involvement. This too can be paucibacillary, so abdominal fluid may or may not reveal the results, so we may wind up doing abdominal tissue biopsies or stool sampling for mycobacterial growth. So it can be a challenging diagnosis to make. This is an individual with immunologically advanced HIV that had disseminated tuberculosis throughout the liver in that regard. This is a colon segment off of bowel resection, just with all that immunologic tissue that's engorged with bacteria, Mycobacterium tuberculosis, and again, having oftentimes in that right-sided colon ileocecal area being a particular hotspot. With pericardial tuberculosis, this may present as chronic chest pain, cardiomegaly on chest x-ray, the ECG, and you guys know this better than I do when it comes to chronic pericarditis, but low voltage in that capacity. It too is paucibacillary. AFB stain results from cardiac tissue is more typically negative or on pericardial fluid. So the diagnosis can be challenging, and it may be the absence of any other solid pathogen identification in somebody with a positive quantiferon and granulomas on a tissue biopsy. That may be as good as it gets for starting combination TB therapy in that regard. Over time, that pericardium gets thickened like leather or sometimes calcified, and this is really thickened, resected pericardial tissue done on a pericardectomy. And this is an old chest x-ray, but it shows that chronic calcification that eventually can develop in individuals with chronic pericardial infection. And this too would be a chronic thickened pericardium. If this guy had an ECG, I'm sure the voltage would be quite low. Other areas that we think about laryngeal TB disease, usually with voice hoarseness. This is an area to be a little concerned on because the infectivity to others can be quite high because TB is right off the vocal cords. Ocular TB can be a challenging diagnosis to make. It can be a variety of different presentations, such as the choroidal tubercles. It also can be more of a hypersensitivity retinitis that we always have our ophthalmology team look at. There's various forms of cutaneous TB, lupus vulgaris-like presentations with chronic plaque-like formations, and this is where our dermatology colleagues can be very helpful. So it's good to know friends in ophthalmology or dermatology to kind of help out with some of these challenging cases. So those are some of the lightning-fast clinical presentations, but then we get into, well, how do we confirm the microbiology when tuberculosis is either on our radar within the differential diagnosis or it's actually confirmed. And so how we teach our fellows is when we look at an individual that we're thinking about tuberculosis of any organ system, is the syndrome, the inflammatory process consistent with active infection or non-infection? So you remember the chest x-ray or the CAT scan I showed you with hyaluradenopathy. Yes, we think primary pulmonary TB because this is a TB lecture, but also, again, histoplasma or blastomyces or sarcoid or lymphoma. If infection's in present, tuberculosis can look like many other things, oftentimes non-TB mycobacteria in the lungs, MAC, Mycobacterium kinzaceae, Mycobacterium abscessus, and the list goes on and on. Nocardia oftentimes can look like this, and select fungal infections. I mentioned histo, but again, we'll see cases, all of you as well, blastomycosis as well, or colleagues in Arizona, coccidiomycosis is high on their radar. So we want to differentiate that by trying to seal the deal with microbial confirmation by stain, by PCR, eventually by culture, and trying to be more comfortable of what this is. Because cultures take so long for tuberculosis, we're talking a bacteria that replicates once roughly every 20 to 24 hours. PCR can be very helpful. In fact, we try to employ PCR now with most of our samples going off to the laboratory. And now we're getting to the point where not only are we able to identify tuberculosis by PCR, but, and I'll talk about this in a moment, select mutations conferring with drug resistance as well. Many of our cases were not able to microbiologically confirm tuberculosis. And so it's about 20% of our pulmonary cases we'll wind up putting on 4-drug therapy regardless, because we're that suspicious of tuberculosis and our ability to identify the bacteria just isn't there. It's culture negative TB, and we look for clinical and radiologic improvement during therapy. Well, what are the diagnostic techniques that we use? All of you are familiar with the AFB, the acid-fast bacilli stain, whether it's the Zeal-Nielsen or Kinyon stain. Our lab actually uses a fluorescent stain called the auramine-rhodamine stain that has a much higher sensitivity to identify bacteria. The sensitivity is quite variable. It's better than 80% with the auramine-rhodamine in that regard, but it's heavily dependent upon the quality of the sputum sample. So if somebody's just coughing up spit, it's going to be useless. We try to get early morning samples, but the quality is really what makes this test helpful. But oftentimes it's going to be negative, and we have to look then towards PCR or towards cultures. When I was a fellow, everything was about solid culture growth, and this took anywhere from 3 to 6 weeks, and it's very slow. Again, these organisms do not grow very quickly. Our laboratory colleagues look for the so-called rough and buff morphology in the agar dish to distinguish Mycobacterium tuberculosis from other Mycobacterium pathogens. Today, most laboratories use liquid broth methods, and this will enable a faster rate of growth down to about 2 weeks. There's the midget system, I believe, which our lab uses as well, and also what's called the Versatrex system, which not only will have the liquid growth, but also enable early detection of drug resistance. So this is important because it really does shrink down the incubation time for early positive results, again, down from 3 to 6 weeks, usually less than 2 weeks. Now, though, we're using PCR, rapid detection, nucleic acid amplification, rapid detection techniques right off of sputum samples or right off of body tissue to make a much more quick diagnosis of tuberculosis. This is helpful when it's positive. It's not helpful when it's negative. On a smear positive sample, this usually can confirm, or if it's negative on a smear positive sample, really make us think about something else like non-TB mycobacteria. And the CDC has now recommended on pretty much every case that with sputum samples, at least one of them should have some type of rapid testing methodology applied to really bolster that sensitivity and rapid diagnostics. We also have an assay available that not only, as I mentioned, does PCR, but also has molecular detection of drug resistance. This is what's called the Expert TB, or previously called Gene Expert. A sputum sample is collected by a patient. It's spun down, entered into a cartridge. There's PCR assay done to identify tuberculosis complex, but also identification of a particular gene in the TB genome. It's called RPOB with select mutations in that gene. When present, this assay will identify that, conferring rifampin resistance. Now, why is that important? Rifampin is the most important drug we have for tuberculosis management, and it's a signal, if you will, that when we have rifampin resistance, most of the time this is a signal for multi-drug resistant tuberculosis, rifampin and INH resistance. So gene experts, or expert TB as this is called, are now being employed across the country, including here at Mayo, for rapid detection of both tuberculosis as well as a screen for rifampin drug resistance. There are other molecular assays looking at a multitude of other gene mutations in the TB genome conferring specific drug resistance to isoniazid, pyrazinamide, ethambutol, the fluoroquinolones, and so forth. I won't go through them here. They're on the slide, but you can see now that we have rapid diagnostics applying to multiple gene mutations conferring drug resistance, and can have a better appreciation up front on optimizing the combination of drug used in therapy without waiting on phenotypic susceptibility testing from culture, which again will be weeks on end. So all of this information then pushes us into how do we best define the treatment? Let's first focus on latent TB infection, as I mentioned earlier. We now have a number of regimens to treat patients with latent TB infection. Again, no active TB disease. This is infection without active disease. Our standard of care here at Mayo and our Olmsted TB clinic is oral rifampin for 4 months, but there are options. Many centers across the country do once weekly high-dose isoniazid and rifapentine for 12 weeks, usually done via directly observed therapy. Sounds like a great program. It is through the health department where they watch you take the medications. It's also about 9 to 12 pills at once. So sounds easy, but it's a fairly healthy cup full of medications to go down once a week for 12 weeks, but it is quite effective. Other options, daily isoniazid's been around for 40 years. It used to be 6 months when I was a resident, then it went up to 9 months, and then CDC brought it back down to 6 months because compliance was much better and there really wasn't much better efficacy with 9 months duration. And in the UK, they're fairly fond of doing daily isoniazid rifampin combination for 3 months, but there's a little bit higher hepatotoxicity risk with that, so we tend to hold off on that. We don't use as much rifapentine, not because it's a bad drug, it's excellent. We've had supply chain shortages across the country with rifapentine, which is why that 3 HP regimen hasn't been commonly used. There is exciting data of other regimens. So this is a little bit old, a couple of years ago, but it was a randomized trial for patients with latent TB infection in multiple centers, over 3,000 patients. And basically, in short, what they demonstrated was that 1 month or 4 months of daily rifapentine and isoniazid was as effective as 9 months of oral isoniazid daily. And many of these patients, in fact, most of them had HIV infection in the African continent. And so this actually showed nicely how a 1 month program of combination high-dose rifapentine and isoniazid could be as effective as 9 months of isoniazid. This is being further assessed and confirmed, but this would be an exciting development if we can reduce the duration of LTBI therapy from 6 to 9 months, or even 4 months if you're looking at rifampin, down to 4 weeks. When I was a trainee, there was a period of time that we were using 2 months of daily rifampin and pyrazinamide, which was effective for LTBI therapy, but did have a higher rate of hepatotoxicity. We indeed had a patient here at Mayo Clinic about 20 years ago who developed liver failure and went on to get a liver transplant from this. But it is an effective regimen. It's no longer recommended because of that hepatotoxicity risk. It's awfully, awfully low, but treatment of LTBI is first do no harm, and because of that higher risk of hepatotoxicity, this regimen's gone out of favor. For multi-drug resistant tuberculosis, these are patients with rifampin and isoniazid resistance combined. Contacts around them with latent infection will treat for latent TB infection, but from an MDR contact. Now, again, because INH and rifampin are both resistant, our options are limited. Historically, we used to think about 2 drugs of second-line therapy together for anywhere from 6 to 9 months. Now, with the newer fluoroquinolones like moxifloxacin and levofloxacin, both of these drugs have very potent anti-TB activity. And so using either levo or moxi for 6 months generally is felt to be sufficient for LTBI of individuals who have contact with an index case of multi-drug resistant TB. Let's now briefly touch on treatment options, updated treatment options for active tuberculosis disease. The good news, and what I tell patients all the time is, hey, you have tuberculosis. This is great. This is not lymphoma. This is not a lung cancer. This is wonderful. It's TB, and they think I'm nuts. But it's very treatable. This is a very, very curable infection in that regard. Yes, it involves taking medications for a long period of time, but we can cure patients quite well. The downside is, unlike community-acquired pneumonia, where we can be fine with anywhere from 5 to 6, 7 days of antibiotics, we're talking 6 to 9 months of combination antimicrobial therapy, directly observed therapy through the health department, many pills, and sometimes medication intolerances. So patients, it is an engaging process with patients, But again, this is very treatable. It's very curable. I won't go through detail of this slide. These are current updated guidelines for tuberculosis published in 2016, and it basically outlines 6 months of therapy for drug-susceptible pulmonary tuberculosis, 4 drugs, INH, rifampin, pyrazinamide, ethambutol, dropping pyrazinamide after the first 2 months, dropping ethambutol when susceptibilities confirm activity, and then continuing INH and rifampin for 6 months. That's the long of the short of this particular slide. But there are other options. So this was kind of an exciting TBTC trial 31 by the CDC and other partnering centers internationally amongst 13 countries, where they nicely showed, compared to standard of care, which is the 6-month regimen that I just rocketed through outlined, that a 4-month program of daily rifapentine, moxifloxacin, isoniazid, and pyrazinamide did as well. In fact, it was simplified to just rifapentine, INH, and moxi after the first 8 weeks of treatment. That this was non-inferior, that a 4-month treatment program could be as effective as a 6-month treatment program and very well tolerated in that capacity. The toxicity rate was felt to be quite comparable in that capacity. Challenges, there's rifapentine, again, drug shortage issues. We don't have wide access to that drug. Moxifloxacin's more expensive. It's a cost issue for many public health departments, and we need to think about fluoroquinolone susceptibility testing up front. Another clinical trial that came out just last year was the Truncate TB trial, and this was an RCT non-inferiority trial, comparing, again, that same 6-month regimen that I outlined with 4 different treatment arms that were lasting basically 8 weeks, a 2-month treatment regimen. And without getting into the details, what they identified is that an 8-week treatment regimen containing bedaquiline and linezolid, along with the standard INH, PZA, and ethambutol, did as well as standard of care. That 2 months did as well as the 6-month standard of care treatment program. There were other arms that they played with, such as using high-dose rifampin with INH, PZA, ethambutol, or rifampin and clofazimine, or rifapentine and linezolid. Neither of them did as well as bedaquiline and linezolid when used in combination with INH, PZA, and ethambutol. So this then raised the bar. Could we think about shrinking durations of therapy from 6 weeks to the TBTC trial 31 to 4 months, now down possibly to 2 months or 8 weeks. And so this is in high consideration as well. The SHINE TB trial came out in 2022. This was with pediatrics ranging between 2 months to infants and 15 years of age with smear-negative disease. And what they found was that 4 months of combination standard of care was as good as 6 months of the published TB regimen guidelines that I had outlined earlier, which makes sense. These are children and infants tend not to have cavitary disease. They tend to have much more paucibacillary disease. And so for these individuals, smear-negative, drug-susceptible pulmonary TB could be treated effectively with just 4 months of therapy. And this actually is now being implemented amongst many of our pediatric patients with active smear-negative pulmonary tuberculosis. So I was part of our writing group. It was a CDC, IDSA, ATS, and European Respiratory Society guideline group, from 2016 to 2019, about drug-resistant tuberculosis guidelines. And none of this had ever been done before. So we spent literally over 2 years, meetings, trips, reviewing the literature. A lot of effort went into this. And finally, this document came out in 2019, and we were proud of ourselves. We were pouring champagne. We were giving each other high fives. This document's out there. 6 months later, literally, no exaggeration, New England Journal of Medicine, we actually knew this was coming in March of 2020, took our document and threw it out the window. Why? Because now we have a new regimen, 3 drugs, bedaquiline, pedominid, linezolid, for 6 months is actually more effective than the guidelines we just published for MDR-TB. This data was actually not available when we were doing our guidelines work. But this now is becoming standard of care, a 3-drug regimen over 6 months. So again, 6 months is what we treat drug-susceptible tuberculosis. Drug-resistant tuberculosis, MDR-TB treatment previously had gone anywhere from 15 to 24 months, ranging between 4 and 6 drugs. So this is really a great development. It was not a bad thing seeing this. Made our job a lot easier. So when we had 6 months of bedaquiline, predominant linezolid, what the data showed nicely is that the success rate was over 90% curative in that regard, which for MDR-TB is staggering, with prior B-PAL regimens, the cure rate was well under 80%, sometimes under 70%, and very risky in that capacity. So there was a lot of excitement behind this. There were subsequent trials that developed from the NICS TB trial. The Z-NICS used a lower dose of linezolid and found that the treatment outcomes were as good as the twice-daily linezolid, but once-daily linezolid has much less toxicity, such as neuropathy, myelosuppression, ocular problems. So standard of care now uses linezolid once daily for TB management that's drug resistant. Then there was the TB Practical trial that came out in 2022 through WHO multi-country trial that demonstrated some degree of increased activity when moxifloxacin can be added to B-PAL in more challenging cases. And so WHO subsequently endorsed not only B-PAL, but the addition of moxifloxacin for 6 months as first-line therapy for MDR-TB and XDR, what's labeled as extremely drug-resistant tuberculosis, when the quinolones are basically active. Here in the U.S., there are options, just using B-PAL, or you could certainly add moxi, which we do when it's more severe MDR-TB disease or CNS involvement or bone and joint involvement. But the point here is, unlike our prior guidelines before 2019 with 4 to 6 drugs over 15 to 24 months, B-PAL plus or minus moxifloxacin for 6 months is now the standard of care for MDR, which is INH and rifampin resistant disease, which is terrific. TB just got a whole lot easier to treat, including individuals with HIV in that capacity. So this is great news, but can we even make it shorter? Can we have better drugs down the road? So in summary, and I know I've been going through this like just a rocket through air, but I wanted to provide some time at the end for questions. Talking with our patients, and this is what I do all the time in our tuberculosis clinic with our patients. I spend a lot of time with them outlining that, yes, this is a good thing. You have tuberculosis. This is great. We can treat this. We can cure this. Honestly, this is much easier to treat and cure than most forms of non-TB mycobacteria. In that regard. That combination TB is effective as long as they take it as instructed, which is why we have directly observed therapy. Treatment is done in a partnership. This is hand and fist what we train our fellows. This is not done by one provider. We do not operate in silos when it comes to TB. We work with our public health departments. This is a team sport. We work with them in the administration of the medications via directly observed therapy. Well, what is directly observed therapy? It is through the public health department, a dispassionate administration of medications to patients on a daily basis. Yes, the main issue is to ensure they're compliant with the medications and that they're taking it as instructed. But what a bonus for the patients is, it's the best way to ensure they're tolerating it okay. There's no better way to ensure patients have that they are safe, that they're not having problems, and that if there's any trouble, we'll identify it probably as early as possible if they're getting their medications via directly observed therapy through the public health department. So this really is a win-win situation to optimize not only completion, but patient tolerability and safety all the way through therapy. And again, it's a partnership with our public health department. Here it's Olmsted, and all 88 counties of Minnesota basically participate with that. So sometimes it does feel like you're alone in the emergency department or in our world in infectious diseases with a case of active tuberculosis disease, but it is a collaborative endeavor with not only public health, but all of you colleagues in the emergency department, colleagues throughout the institution, working together to both early diagnose this infection and overall cure the disease. And I'm from Nevada originally, and sometimes it feels like you're in the middle of a desert driving alone, but really this is a communal environment, and none better than here in Rochester to have colleagues in certain places to call with questions or just moral support if you're feeling down and out with a tough case. That's what we're here for. So with that, there's a couple of minutes that I wanted to leave available for any questions.
John, thank you so much for reaching out and wanting to teach us. You and your team are incredible colleagues and clinicians, and we learned so much from you all. Listeners, thank you for continuing to join Alex and me on this podcasting journey. Come back June 1st for our next chapter. It's going to be really great. We have been sitting down with pretty outstanding people almost every week. They have been opening our eyes to wonderful things that we can't wait to share with you all. So until then, thank you for listening, and go enjoy yourself.
The Always On EM Podcast.
Emergency Medicine Grand Rounds.